All right, so pre-analytical variables. So these are anything or variables that occur before the specimen is tested. So a variable is any factor that can be measured or counted that will affect the outcome of the test results and ultimately patient care. So the phlebotomist is actually the most responsible for pre-analytical variables. If you think about it, we are the ones who are drawing the sample or collecting the samples. So that is, obviously occurs before any testing is performed. Specimen collection accounts for more than half of errors in pre-analytical variables. So I also need to keep in mind that pre-analytical variables, especially with patient collection, it really is more of it's not an analytical process. It doesn't really have the computer parts to be able to catch some of these errors. It's really human driven as far as us looking at the patient information, making sure we have the right patient and the right sample type and anything like that. Analytical variables, like I mentioned, so that is when the testing is actually performed as analytical variables, and that can be affected by the pre-analytical variables. Many of the pre-analytical issues will arise during patient preparation and specimen collection. One of the most important day-to-day and hour-to-hour fluctuations is the composition of blood. So to minimize effects of day-to-day and hour-to-hour fluctuations in composition of blood, the reference ranges for blood tests are based on healthy patients and what is known as the basal state of the patient. In the hospital, the routine phlebotomy rounds are generally scheduled for early morning, and that is because that's when most patients are in their basal state at that time. So some variables of patient condition and preparation that could affect stuff as well is the age of the patient, if they've had any alcohol, the altitude. So if you are working somewhere like Denver versus Florida, that can cause some issues as well. If the patient is dehydrated, if they have a diurnal variation, exercise, if they exercise a lot, if they're fasting, which means if they've had something to eat or drink, or if they haven't, their sex, if they're male or female, if they're on certain medications or certain medical treatments, that can also skew some results. Patient posture can also play a role in this, as well as pregnancy and obesity. So the patient's physical condition at the time of collection will have a significant impact on the sample quality. Bariatric chairs should be used for outpatients, and you can use a blood pressure cuff instead of a standard tourniquet, which can also help improve the access to the vein if needed. Factors that can prevent access to the patient. So a lot of times this is going to be an inpatient type situation, so in the hospital. So locating the patient. Sometimes they're not where they're supposed to be, and that could be because maybe they're with their nurse taking a walk, or maybe they have another procedure or something else is going on. So locating the patient can be an issue sometimes. So if the patient is not in their room, make sure to make every effort to try to find the patient by checking with the nursing station. If the patient is in another department and the test is a short turnaround time, like a stat or a timed request, you need to go to that area to draw the blood there. You need to make sure to look at the status request of the blood draw, because if it's stat or time, those are important to get done. If it's timed, within 15 minutes or so of that time, and if it's stat, it needs to get done immediately. Identifying the patient. So as you learned earlier in previous lectures, positive ID of the patient is the most important procedure in phlebotomy. So identifying that patient is extremely important. So if there are any discrepancies, we have to resolve those before collecting the specimen. So if you look at the wristband and it doesn't match your labels, you need to remedy that. If the patient gives you a different birth date than what's on their wristband, you also need to make sure that nursing or somebody is aware of that as well, because that is not correct either. There is also sometimes it can occur where the band is missing, so they're not wearing their ID band. We also need to contact nursing for that as well, because usually only the nurse can put those on the patients. So identifying the patient, you have several situations, like I mentioned, that can make identification difficult. And this can be if it's an emergency. So someone comes in through the ER and they don't have any identification yet. That could cause issues. Emergency rooms in general can cause issues as well. If they come in, sometimes it's a crazy stressful situation. They might not get all the correct information. Getting orders through the telephone, sometimes we call those verbal orders in the laboratory. We need to make sure we document those if that does happen, and make sure you follow your policies, protocols, and requisitions that are picked up at the site. Sometimes things aren't filled out appropriately. Again, we're all human, things happen, so just make sure we double check everything. So despite the difficulties these situations may present, the information on the requisition has to match exactly what the information is on the patient's ID band for an inpatient. If they're outpatient, you need to make sure it matches exactly what the patient is stating. If it does not, we need to alert somebody about that, because it can cause issues with not just the lab, but with pharmacy and nursing and other departments like radiography as well. They need to have proper patient identification too. Sometimes there are barriers with the patient communicating. So especially in an inpatient situation, they could be sleeping or unconscious. So if you encounter a sleeping patient, you need to make sure that you try to wake the patient up and give them time to become oriented before you do the draw. Sleeping patients cannot give informed consent or confirm their identity, so that's kind of why, obviously you don't want to be woken up from a needle either. So make sure you are trying to do that. Drawing from a patient without their consent, once again, may expose you to charges of assault. There are times when you must draw from a patient who is unconscious or cannot be awoken. So you need to make sure that you treat an unconscious patient just as you would a conscious one, including identifying yourself and describing the procedure. These unconscious patients are usually found in the ICU, emergency department, and sometimes nursing homes as well. Lots of times, obviously, if they're unconscious, they can't respond to you, but a lot of times they can still hear you. So that is why it's important to still assume that they are conscious and tell what you're doing and introducing yourself, because I could only imagine how scary it would be if you're not able to verbalize, you're not conscious, but you can still hear what's going on, and all of a sudden, you feel pain. So just kind of keep that in the back of your mind when you are with these patients, or really any patient at any point. Some more barriers for communicating with the patient. So presence of physicians or clergy in the room. So a physician or a clergy member may be in the room. Lots of times you want to return at another time for the procedure, unless it's a stat or timed collection. So if it's something that's routine, you can always come back later. It's not something that has to be done right away, like a stat or a time collection. In that case, you should respectfully interrupt and explain the reason for the interruption. If it is a stat or timed, letting them know why you're there. Because lots of times with the physicians there, it's usually, they're talking to the patient or there's some explanation that needs to be done. So we just need to let them know, hey, we're here for a stat lab, and they will more than likely allow it to occur. If the physician enters while you are preparing to draw, leave the room until he or she is finished with the patient. Again, this is going to go back to the protocols of your facility, so just make sure you're up to date on what you need to do there. Presence of visitors. So if there is a visitor in the room, make sure that you greet them just like you would the patient. Explain, once again, why you're there, and ask the visitors if they wouldn't mind stepping out. Some will want to stay, some will not, so just make that an option for them. Most visitors will exit, like mentioned, to leave you to work without distraction. If the patient is a child, the presence of a visitor or family member usually can help during the collection. It can help calm them down in times like that, because children are generally pretty scared of blood draws. So if you have an apprehensive patient, so someone that just doesn't really want to be drawn, a lot of patients have that apprehension about being stuck with a needle or having their blood drawn. So lots of times with patients, you can easily calm them by engaging them in a conversation on neutral topics like weather, traffic, local news, things like that. Just kind of keep the conversation light, and that can usually help distract patients as well. Language problems. So if you are having issues with someone who speaks a language other than you, or that you just can't understand, and you can't get that informed consent, then you may need to ask for a translator in that situation. Again, talk to your facility and see what the protocol is for this situation, but most facilities will have a translator available for patients. Patient refusal. So if the patient refuses, they always retain the right to refuse a blood collection. So we cannot force them to do that. So if that does happen, you're going to thank the patient and you're going to leave the room. Like I said, you're never going to force the patient to have the blood drawn, but you are going to try to find that nurse and explain that the patient has refused the procedure. Sometimes that nurse may go back with you, or just may go to the room themselves and try to talk to the patient and tell them. Lots of times they're going to try to explain why it's important for them to have this done. If the patient refuses again, just make sure you document this on the request along with the nurse's name that you talked to, and then notify the healthcare provider. Your facility may have a different protocol on that, so make sure you are aware of what that is. But most of the time, you're going to inform the nurse, and sometimes they'll talk to the doctor. Sometimes they're going to want you to call. It just kind of depends. But either case, if the patient refuses, they refuse. You cannot force them to do it. If you have problems at the site collection, so there are times where you go to the vein and there's an issue. So the antecubital fossa is the most common site for routine venipuncture. However, the presence of certain conditions at that site may alter the quality of a specimen or cause harm to that patient. So if you run into any of these issues, then you need to choose another site for the blood draw. So one of those issues is having occluded or sclerosed veins. So these are veins that are occluded, which are blocked, or sclerosed, which are hardened. So when you go to feel that vein, it's going to feel almost like a cord inside of their arm. So it won't be that normal bounciness like a vein has. Occlusion and sclerosis can be caused from inflammation, certain diseases, if the patient's had chemotherapy, if they've had prolonged IV therapy, or they just had a lot of blood draws. That can all cause these to happen. These veins are susceptible to infection, and because the blood flow is impaired, the sample may produce erroneous results. Hematomas. So hematomas are another issue that you could run into when drawing blood. So hematomas may be caused by the needle going through the vein, by having that bevel opening only partially in the vein. So it's in the vein, but not all the way, so the blood is kind of coming out, or by failing to apply enough pressure after you have removed the needle. Blood from a hematoma is no longer fresh from the vein, so the hematoma may obstruct the vein and might slow the blood flow. You might also find tissue that is swollen. So the arm may appear swollen because of accumulation of tissue fluid. So that can cause issues with drawing blood as well. And if the patient has burns, scars, or tattoos, these areas generally will have an impaired circulation, and they are susceptible to infection, and they may be painful or difficult to penetrate to try to get that vein. So try to avoid these areas as well. Patients who have had mastectomies, this is the removal of lymph tissue on the side of the mastectomy that can cause lymphostasis or lack of lymph fluid and movement, so they can have some buildup over there. The collection also may be painful to the patient, and the risk of infection may be increased. So depending on your facility, once again, your institution may require a physician's consent before drawing on the same side of the mastectomy. Lots of times they're going to say you can't draw. So if they've had a mastectomy on the right side, they're going to say that you can't draw on that side. Again, your facility has their own protocols, so make sure you are aware of that. IV sites. So blood should not be drawn from an arm if there is an IV device in place. You're going to try to use the other arm or an alternative site. If there are no other sites available, blood should be drawn from a site distal, so farther away from the IV. And generally, you're going to go below the IV as well. So if somebody has an IV in the middle of their arm, sometimes you can go like in their hand. That would be distal from it if you had to use the same side. Any condition resulting in disruption of the skin integrity means that the site should be avoided. So if they have really loose kind of skin that's kind of falling apart type situation, we want to stay away from that as much as possible. If there's any open or weeping lesions or skin rashes, if someone has just gotten a tattoo, or if they have incompletely healed stitches, we want to try to avoid those areas because they're going to be at an increased risk of infection. So if you are having difficulty in finding a vein, when you are having issues, there are several techniques that can help. One is to check the other arm. So examine the other arm for a suitable site. You can also ask the patient and see, they know the best sites. They know where they've had blood drawn before. So ask them and see if they know where they have been drawn before. You can also enhance vein prominence by massaging gently upward from the wrist to the elbow. Dangling the arm in a downward position can also help to increase blood in that arm as well. You can apply heat to the area, which can help get those veins popped up a little bit, and you can also rotate the wrist to increase the prominence of the cephalic vein in the arm as well. So you can also use a blood pressure cuff instead of a tourniquet if you are having issues finding a vein with a tourniquet. It should be placed 3 to 4 inches above the venipuncture site and inflated to a pressure above the diastolic but below the systolic reading. You can also use an alternative site like mentioned earlier. The leg and foot are more susceptible to infections and clots, and they are generally not recommended sites for patients with diabetes or those on anticoagulant therapy such as heparin or warfarin. Collection from the leg and foot is also going to require a physician's written permission. So this is not something that you're going to look at their arm, not see anything, and jump to their leg. It's going to be a whole process that you're going to have to actually get written consent from the physician for. If you are able to do it from a foot or a leg, you will use a winged infusion or a butterfly set to collect that. And another option is you can draw with a butterfly or winged infusion set as well on the back of the hand. Problems associated with cleaning the site. So 70% isopropyl alcohol, methanol, ethyl alcohol, or tincture of iodine cannot be used to cleanse sites for blood alcohol test. So if you think about it, all of those are made with alcohol. So if we are testing for alcohol and we clean it with alcohol, it's going to go ahead and give us a false reading for that. So it will contaminate the blood, which will cause a false positive. So we are actually going to use providone iodine or benzalkonium chloride instead for those types of collections. Problems associated with the tourniquet application. So if a tourniquet remains in place too long, the plasma portion of the blood can filter into the tissue, which can cause an increase in the proportion of cells remaining in the vein. Prolonged tourniquet application can also alter potassium and lactic acid levels by a different mechanism. So it can cause hemoconcentration. It can form petechiae, which are small, non-raised red spots that can appear on the skin when the tourniquet is applied to a patient with a capillary wall or a platelet disorder. The tourniquet can be applied too tightly, and it could potentially be made of latex, and that could cause a latex allergy. All right, for a winged infusion or a butterfly collection in the hand, the procedure can be found in your book and also in this video here on the slide. But you're going to assemble your equipment. You're going to position the patient's hand and apply the tourniquet. The tourniquet is usually going to be, up by the wrist, maybe a little bit higher than the wrist on the arm. Once you have found the vein and have cleaned appropriately, you're going to insert the needle. Then you're going to collect the sample and finish the collection. You're going to attend to the patient and then dispose of that needle into the puncture-proof biohazard container. So there are complications that can occur during venipuncture. One of them is syncope, and that is the medical term for fainting. So before a patient faints, the patient's skin will often feel kind of cold, damp, or known as clammy. Sometimes they'll have beads of sweat that may form on their forehead or upper lip. Patients may state that they are not feeling well. They may stop talking. Their eyes may roll to the back of their head, or their head could tilt either forward or backwards. So it can happen. Don't be scared when it does happen. It happens. Just know what to do if it does happen. So fainting is more common with outpatients, and that's because inpatients are usually in bed already, so that kind of leaves them already less likely to faint. So if syncope occurs while you are drawing a patient, make sure you remove the tourniquet and needle immediately and apply pressure to the site. Outpatient draw areas should be equipped with pillows and blankets just in case this does happen. And if a patient does faint, make sure we document this as well. Seizures could happen during a collection. So if a patient has a seizure during the procedure, remove the tourniquet and needle immediately and apply pressure to the site as well. If somebody has some nausea and vomiting during the collection, you're going to reassure the patient and make him or her comfortable. So you're going to want to try to give them a basin to throw up in, and instruct him or her to breathe slowly and deeply. Pain can happen, so to prevent the startle reflex, warn the patient before the needle stick that there may be a little poke, pinch, or a sting. That just lets them know what's occurring so they don't, flail their arm up when you put the needle in, because that wouldn't be good either. A hematoma can occur as well. So when blood oozes from the vein into the surrounding tissue, that is how a hematoma is formed. If this occurs during the procedure, you want to remove the tourniquet and needle immediately and apply pressure to the site. You can see the skin surrounding the punctures swell up and fill with blood, so it'll kind of look like reddish under the skin, maybe even bruised looking immediately as well. And when that does occur, you can use a cool cloth or a cold pack, and that can help slow the swelling from blood and ease the pain for the patient as well. Sometimes you will have a lack of blood flow. So the lack of blood flow can be caused by a defective tube, or maybe that the needle is not positioned properly, or that you just miss the vein, and that happens sometimes too. So a defective evacuated tube, occasionally blood will not flow into a tube because the vacuum in the tube has been depleted. So this can occur from manufacturing defect, if the tube is expired, or sometimes if there's like a really small crack in the tube that maybe we don't see because it's been dropped, that can also cause the vacuum to not fill. So if you see intermittent or slow blood flow, that can indicate a proper or improper needle position or a collapsed vein. Always take extra tubes to the bedside or the outpatient area just in case something like this does happen. You don't want to have the needle in the arm and not have your supplies ready, and not be able to reach, the extra tube that you need. So just make sure you have some extras that you can reach. And if you find a defective tube, be sure to note the expiration date and lot number, because it could be more than just that one tube, right? It could be the whole box of tubes that we just got in, could be the issue. So we need to make sure we document these things as well. All right, so an improperly positioned needle. So when the needle is not in the correct position with respect to the vein, the blood flow may stop or be intermittent. So if the tube is not the problem, the needle may be. And it could be, like I mentioned, that it's just not properly positioned and you may need to adjust it. If the tube is too large for the vein, it could cause excessive vacuum in the tube, and that could pull the vein into the bevel, and that could actually block the blood flow as well. You can also have a collapsed vein. A collapsed vein is caused by too much vacuum on a small vein. When using the evacuated tube system, a collapsed vein becomes evident when the tube is pushed onto the inner needle. So once a vein collapses, you're going to remove the tourniquet, pull out the needle, and select a different vein, or switch to using a butterfly on the hand vein. Veins that roll excessively, you're going to want to anchor that vein with the free hand, so with your thumb or something, kind of try to anchor it, keep it in that spot, and that will kind of help it if you got some rolling veins that you're dealing with. So inadvertent puncture of the artery can occur. So puncture of the artery can produce a bright red blood, and you'll notice the difference for sure when you are drawing blood. Your venous blood is going to be kind of a darker red, whereas your artery is going to be kind of a bright red. And if you do get that artery, you may see that it's spurting or pulsating the blood into the tube versus just filling the tube like normal. If you do get an artery, make sure you let the nurse know that you have punctured the artery. They may or may not do anything about it, but you just need to make sure you let them know. Failure to collect on the first try. So the policy at most institutions is that you are able to try twice if you were not successful the first time. After that second time, if you are still not successful in getting blood, then that's when you need to find another person to draw the blood for you. It's okay. It happens, but just let them know, that you weren't able to get it. You tried twice, and someone else needs to go try. If you do try a second time, you need to make sure you have a new needle and tube. You do not want to reuse needles ever. And for second tries, you're going to want to go below the previous site or just try a different site completely. You don't want to try to use that same puncture location that you were just in. Problems in completing the procedure. So sometimes the patient can request that they want something different, right? So sometimes a patient may ask you for water or a change in bed position. You're always going to check with the nurse before you comply with any of the requests, because maybe they can't have water because they're going to have a procedure. As far as bed positioning, as a phlebotomist, we are not going to be positioning patients. That's going to be up to the nurse, so we're going to let them know that as well for them to help with those patient requests. Patients can have prolonged bleeding as well, so normally the site should stop within about 5 minutes, but in all cases you must continue to apply pressure until the bleeding has stopped. If for some reason it's taking a long time, you're going to want to inform the nurse as well, because maybe they're on blood thinners, so maybe they need a little bit longer, pressure being held on that as well. So failure to apply adequate pressure, particularly with patients on those blood thinners, can cause compartmental syndrome, which we will talk about later. So there are factors that can affect sample integrity as well. One of them is hemolysis. Hemolysis is the destruction of the red blood cells, which can result in the release of hemoglobin and cellular contents into the plasma or serum. So the serum or plasma will turn this pinkish red color as shown in the picture below, and that is how we know a sample is hemolyzed if we're looking at it like that. So that first one that's kind of yellowy looking, that is a normal sample. That's what most of them are going to look like. And then as you can see, 2, 3, and 4, it progressively gets worse. And that's just the level of hemolysis that has occurred. So causes of hemolysis. So blood frothing caused by a needle improperly attached to a syringe can cause hemolysis. Drawing blood too quickly into a syringe, so pulling back on the syringe too fast or making it fill too fast can cause hemolysis as well. If you're excessively shaking or rotating the blood, that could potentially cause it as well. Failure to allow the blood to run down the side of the tube when using a syringe to fill the tube, forcing blood from a syringe into a vacuum tube, and using too small of a needle in respect to the vein size can also cause hemolysis. Some more things that can cause hemolysis is using a needle smaller than 23 gauge, using a small needle with a large vacuum tube, using a small needle to transfer blood from a syringe to a tube. There's a little bit of a consistency here, right? Smaller needles. So just kind of keep that in the back of your mind too when patients are requesting those butterfly needles. Just make sure they are aware that their sample may not be as good. There could also be some mishandling or improper transport of the specimen, and readjustment of the needle in the vein can also cause hemolysis. Tests that are going to be affected by hemolysis, the ones that are seriously affected are going to be your AST, your potassium, and your lactate dehydrogenase. The ones that are moderately affected are going to be your ALT, CBC, your serum iron, and your thyroxine. Slightly affected ones are going to be your acid phosphatase, albumin, calcium, magnesium, phosphorus, and total protein. Some more factors that can affect sample integrity is blood that is drawn from a hematoma. So the blood in a hematoma is actually older than the blood that we would get from a vein, and use of that blood could actually alter the results of some of those tests. The most frequent cause of hematoma is improper insertion or removal of the needle, and that actually causes the blood to leak or be forced into the surrounding tissues. Patient positioning. So the standard position for blood draw from an outpatient is with the patient seated, so just seated in that chair. But there is some circumstances where a physician may request that the outpatient lie down before the specimen is collected. Reflux of anticoagulant. So reflux is the flow of blood from the collection tube back into the needle and then into the patient's vein. This is very rare, but it can occur when the tube contents come in contact with that stopper during the draw. Tests that can be affected by patient position are listed here. Long-term complications that can be associated with venipuncture is you could have iatrogenic anemia, which is anemia that's caused by excessive removal of blood at the request of a physician. So they're having lots and lots of blood drawn, but also it could be from the removal of as little as 3 to 4 milliliters of blood per day, which could also result in the development of iron deficiency anemia in some patients. So we also have compartment syndrome. So patients receiving excessive doses of anticoagulants such as warfarin or who have a coagulation disorder such as hemophilia, routine venipuncture may cause bleeding into the tissues surrounding that puncture site. So there are larger amounts may cause compartment syndrome, a condition where the pressure within the tissue prevents blood from flowing freely into the blood vessels. You can also cause nerve damage to patients. So nerves in the antecubital area can be damaged if they are contacted with the needle during collection. So to prevent nerve damage, we're going to avoid excessive or blind probing during the venipuncture. So if we go in and we don't get blood right away, don't take that needle and just start, going back and forth and moving it around a lot because you do have the potential of hurting somebody and causing nerve damage. So infection can also occur, and that can be prevented by adhering to the protocol, such as cleaning the site and not touching that site after it's been cleaned. So we need to make sure that we are using proper aseptic technique before and during collection to reduce the risk of infection. Specimen rejection, there's a whole bunch of different reasons why they can be rejected, and it could potentially be by facility as well. So the list here are pretty common ones of why samples could be rejected, and almost all of these can actually be avoided by proper care before, during, and after the procedure.